Hello, everybody. This is Dr. Abdelkader Ashur. Today, we are going to continue and finish this series of videos about pharmacologic treatment of heart failure. We started with pathophysiology of heart failure, then drugs in the management of heart failure. And today, we are going to continue the second part of inotropic agents in the management of heart failure, which will start right now. Well, in this part 2 of inotropic agents in the management of heart failure, we will discuss electrophysiological actions of cardiac glycosides, their clinical uses, toxicity, and their interactions with these electrolytes, potassium, calcium, and magnesium. We'll discuss also the last two classes, which are the phosphodiesterase inhibitors and beta-agonists with regard to their mechanism of action and their useful and side effects. As we said, this is the last video about this management of heart failure, which will include the remaining part of cardiac glycosides with phosphodiesterase inhibitors and beta-agonists. Okay? So just as a quick recap, digitalis or digoxin, they inhibit sodium-potassium pump. When they do that, more sodium will stay inside, so more sodium here. So now there is no, this exchanger will be inhibited, cannot exchange calcium with sodium, because more sodium is inside, more positivity here. Okay, so so it will not, so I already have more sodium here, so I don't need to bring sodium, so there is no concentration gradient for sodium to enter, so more calcium, more contraction, okay? So digoxin increases the force of contraction. It's cardiotonic. As I said before, it has positive inotropic action, so by increasing the force of contraction, will increase the stroke volume and increase the cardiac output, which is the thing you are missing here. We need to increase the cardiac output, okay? The increased myocardial contraction increases ejection fraction, which we are looking for. It was 20% or less. Now we need to increase it to above 40, 50%, okay? And this in turn will decrease in diastolic volume. This actually is usually a question by students, why the diastolic volume decreases. Well, number one, the hemodynamics, the circulation now is getting better. Now there is more blood is moving in the circulation. There is no remaining blood or diastolic volume more. But the direct answer to that comes from two things. Number one, if there is more blood coming out of the heart, okay, more stroke volume, more cardiac output coming, so more renal perfusion. If there is more renal perfusion, there is less activation of or no activation of the juxtaglomerular cells to produce renin, and the whole RAS system will be inhibited, which usually ends with vasoconstriction and sodium water retention. So if I inhibit sodium water retention, there is decrease in the diastolic volume. The second thing is the reduced sympathetic activity, because now there is good circulation now. There is no need to you know, the baroreceptor, you know, when we talked about the compensation, so now the circulation is okay, so the baroreceptor will inhibit the sympathetic activity. So this also will reduce the, will cause, this will decrease the sympathetic activity, and sympathetic activity, as you know, they induce or activate the beta receptors in the juxtaglomerular cells, okay, so to produce renin and the whole RAS system. So also this will be inhibited. This again will decrease the sodium water retention and decrease the volume overload in the circulation and in the diastolic volume. Okay, and this also, the reduced sympathetic activity will reduce the peripheral resistance. So now the heart can pump blood through a wide blood vessels, wide hose, easy to pump, okay? As we'll explain later, the digitalis or the digoxin induces in low doses the parasympathetic nervous system. So it has some parasympathetic activity, so they will increase the vagal tone, This will decrease the heart rate, okay, and in turn will decrease the oxygen demand. That's why I don't like to call them cardiac stimulants, because cardiac stimulant for me induces heart rate and contractility. They induce contractility within the normal therapeutic dose. They should not increase the heart rate. Actually, it should decrease the heart rate. So all of these are the mechanical effects of digoxin. Okay, the increased contractility is a mechanical. The increased heart rate is the mechanical effect, which result in decreased oxygen demand. So the second effect is the electrical effect, which are either direct or autonomic effects. Okay, direct actions, okay, starts with brief prolongation of the action potential, followed by shortening of the action potential, especially in the plateau phase. Okay, so the decrease in the action potential duration is due to the increased potassium efflux, okay, which is caused by increased intracellular calcium, because now digitalis increased calcium inside. We agreed, right? Okay, we agree? Okay. So now more calcium inside. So potassium efflux will be more, okay? There are potassium leak channels. Okay, so now potassium efflux can be more because positive is positive, I hate you, repulsion, repulsion, get out of my face. All of these things will happen, kind of like that fight will happen. So potassium efflux will be more. Potassium efflux more, okay, so the plateau will be shortened because potassium efflux will result in more negative voltage. So negative will go quickly, so it will take the action potential quickly toward the negative side of the action of the voltage. Okay, all these effects are just in the therapeutic dose. At higher concentrations, even resting membrane potential will be reduced. Why? Because also there is less, because now potassium efflux is more, right? So less potassium inside the cell, so even the resting membrane potential will be decreased. Okay, when you have more toxicity, whatever it's called, delayed after depolarizations, or they call it after potentials, okay, appear following normally evoked action potential. So action potential, action potential, okay, like that. So, but there will be something in between, which will be called delayed after depolarization DADs, okay. When these DADs accumulate or reach a threshold, they can elicit action potential. So they will produce beat. It's called ectopic beat because it was out of the norm, okay? It was not there at all. So now this will be translated into more beat. More and more and more will produce tachycardia. Tachycardia may deteriorate into fibrillation. If it is ventricular fibrillation, it is an emergency. It can lead to death. It has to be dealt with instantaneously. This experiment shows the effect of ovabine. It's one of the digitalis or cardiac glycosides on the heart. Okay, so here this is a control, just solving nothing. So this is the normal plateau of the heart. Okay, this is the membrane potential. When you give ovabine, this is the therapeutic level of therapeutic duration. So there is shortening here. You see here, notice shortening of the action potential plateau. At toxic level or toxic duration, when the ovabine reaches toxicity, it will result in further shortening of the plateau. And you see here, this is the dad, not my dad or your dad, okay? Not ayah, or not in Malay language, or father, okay? It is just small after potential, okay? But when this, as we said, like reach, like go more, we have more and more and more of this, it can make independent action potential, which will result in extra beat and tachycardia. This is the level of calcium, because this is a model of heart failure animal, okay? So less calcium, here more calcium, and it will appear here in the extra beat, or along with the extra or the delayed after depolarization, the DAD. Okay, regarding the contraction, weak contraction is heart failure. Okay, so there is increase in contraction, and there is extra contraction here. Okay, so this kind of show you the all effects, but in actual experiment. Okay, autonomic actions of the digoxin on the heart involved. Yeah, it's parasympathomimetic and at low or low therapeutic dose. Okay. But sympathomimetic in high toxic dose, okay? So this is the parasympathomimetic effect is responsible for the electrical effects we talked about. These dose digoxin also inhibit the sympathetic nervous system activity. So at low dose, the parasympathetic system will be predominant, sympathetic system will be inhibited, which is good at low dose. So because cholinergic innervation, yes, is much richer in the atria. You know, the parasympathetic nervous system supply atria mostly, very less or no supply to the ventricles. Okay, so the parts that will be affected are the atria and AV node without so much effect on the Purkinje or ventricular function. Okay, some of these effects are very useful in treatment of some arrhythmia. Actually, one of the uses of digitalis or digoxin is arrhythmia, and one of the some side effects are also arrhythmia. We'll see in a bit. At toxic doses, sympathetic activity will be more. Okay, will increase. Okay, side effects. Okay, digitalis is one of the very common examples, or one of the notorious examples of the drugs with narrow therapeutic index. The difference between the therapeutic dose and toxic dose is very slim. Okay, so if you remember, we said the pharmacokinetics, the T-half is about 40 hours, 36 to 40 hours. So this prolongation, okay, you have to be careful when you give the second dose. Okay, so you have to keep the dose within that certain therapeutic window. You don't, because it's easy to go from the therapeutic dose to the toxic dose. Okay, so the common manifestation of the digoxin toxicity include ectopic beats. You remember ectopic beats when we talked about dads, my dad or your dad. Okay, these ectopic beats that can evolve into a full action potential. Okay, so this can cause ectopic beats of AV junctional. So this is called AV junctional rhythm. So it will go more on the AV, so it will have more rhythm of the AV. Remember, we have SA node AV, so it will be more following the AV node, because the conduction there will be more and electricity, so it can the rhythm will follow the AV, the atrioventricular junction. Atrioventricular block, because if you remember, we said also it can inhibit the inhibit the sympathetic activity and activate the parasympathetic nervous system, can result also in atrioventricular block. Premature ventricular depolarizations. Okay, so this is the cause of the ectopic beats. Okay, ventricular tachycardia, which can develop into atrial fibrillation, which is fatal. Okay, it's claimed that digitalis can cause virtually any kind of arrhythmia. Okay, everything you think about digitalis can cause with regard to arrhythmia. Because of this toxicity, very severe toxicity, it require administration of anti-arrhythmic drugs, because there is arrhythmia, anti-arrhythmic drugs, okay? But also they developed antibodies to digoxins called digoxin immune fab, like Digibind and Digifab. Okay. Side effects, but on other organs like GIT and CNS. On the GIT, they can cause nausea, vomiting, diarrhea, anorexia. Okay, all of these are due to direct effect of the drug on the GIT, and also on the CNS. On the CNS, if you remember, because it can activate the chemoreceptor trigger zone, which can lead to nausea and vomiting, and also the increased vagal activity can increase spasm and also can cause diarrhea, and all of this also can, the high peristaltic movement also can lead to some sort of nausea, vomiting, and anorexia. Least often disorientation, hallucination, visual disturbances. Okay. The interaction with the electrolytes, potassium, calcium, and magnesium. For potassium, please remember the mechanism of action. The mechanism of action is inhibition of sodium-potassium pump. it competes with potassium for the binding site on the sodium potassium pump. So this is digitalis. So this is digitalis, okay, and this is potassium, okay. Both they compete for this sodium potassium pump, okay. They compete. So whoever is more will win the situation, okay. So you expect if there is hypokalemia, less potassium, so means the digoxin can bind more. The digoxin or digitalis can bind more, right? So more toxicity, right? If there is severe hyperkalemia, this means that this will inhibit the action of digoxin. Okay, so what is the advice here, doctor? Just take small dose of potassium. This will help so moderately increased extracellular potassium can reduce the toxic effects of digitalis or digoxin. Calcium, because remember the mechanism also involved enhancement of increase in the level of calcium inside the cells. So if you add calcium, this will increase the toxicity of digitalis, okay, and it will affect also the abnormal automaticity as we explained in the side effects. So hypercalcemia increases the risk of digitalis-induced arrhythmia. Magnesium is kind of similar with regard to potassium. So hypomagnesemia increases the risk of digitalis-induced arrhythmia. These interactions require careful evaluation of these electrolytes, okay, in patients with digitalis-induced arrhythmia. Therapeutic uses, its major indication is heart failure with atrial fibrillation. Okay, atrial fibrillation means there is tachycardia on the level of the atria, but it's erratic, okay? So erratic impulses are coming, okay, in conduction, so it's not normal, so it can decrease because, as we said, at therapeutic doses, it decreases towards on the AV and on the atria, right? So it can decrease the these ectopic beats and at therapeutic dose. At therapeutic dose, it can decrease the heart rate, so it can deal with the atrial fibrillation, okay? So slow ventricular rate in rapid persistent atrial fibrillation, because atrial fibrillation can also brings with it increased ventricular rate. Severe left ventricular systolic dysfunction after initiation. So now the main use, okay, when the patient has systolic heart failure, not diastolic. It's not used for diastolic or right side heart failure. Systolic heart failure, but after initiation, so you see here, our beloved two groups of drugs, the ACE inhibitors and diuretics, okay? So patients with mild to moderate heart failure will often respond to treatment with ACE inhibitor and diuretics, and they do not require digoxin. And it's not indicating patients with diastolic or right-sided heart failure. Diastolic, okay, diastolic heart failure results from hypertrophy, decreased stiffness of the myocardium. So the problem here is not the contractility. So it will not add anything, it will just add toxicity. And right-side heart failure. Paroxysmal supraventricular tachycardia and atrial flutter, because it will decrease the heart rate. Okay, it's just a comparison between it and dobutamine. Dobutamine is beta-1 agonist that we will discuss at the end of this video. Okay, it's taken parenterally, but the only inotropic drug that's given orally is digoxin. Okay, in addition, unlike other positive inotropes, digoxin does not increase overall mortality. So the other drugs can increase, the phosphodiesterase inhibitors and the beta-agonists may increase mortality. They found some anti-cancer effect of these drugs, and the clinical trials are currently going on. The second class of inotropic drugs is phosphodiesterase inhibitors. They call them Bipyridines, okay? Milrinone is bipyridine compound that inhibits phosphodiesterase 3. Okay, if you remember when we talked about the GS protein coupled receptors, we say they activate adenylate cyclase. Adenylate cyclase converts ATP into cyclic AMP, right? Cyclic AMP will activate protein kinase A. Here, remember the there is an enzyme that can degrade cyclic AMP. So I have adenylate cyclase that can convert ATP into cyclic AMP in one hand. I have another enzyme which is phosphodiesterase that can degrade cyclic AMP. So I can increase cyclic AMP by beta agonists, okay, or by drugs that inhibit phosphodiesterase, inhibit the inhibitor, right? So inhibition, this increase calcium by increasing onward calcium flux. We'll discuss this in the next slide, how to increase calcium during action potential, and therefore, so it will increase calcium. We said inotropic drugs, all of them increase calcium and increase cardiac contractility. Like beta-adrenoceptor, they increase calcium and can cause arrhythmia, okay, because the beta agonists also increase heart rate. Examples are milrinone, the one that's already used, but inamrinone is obsolete now. Long-term milrinone therapy will be associated with increased risk of of mortality. Remember, we said that about digitalis or digoxin. It is the only one that's not associated with increased mortality. Short-term use of milrinone, IV milrinone is not associated with increased mortality. So just if you use it, just use it very short period of time. So the mechanism. This is a beautiful part here. Okay. So now there is here. Let's start the story. Actually, this part is the mechanism of action of beta agonists, such as dobutamine, which will come at the end of this video. Okay, and this part is the part that's related to the phosphodiesterase inhibitors. So binding of beta adrenergic agonists, such as dobutamine or dopamine. These two examples will come at the end. Activate adenylate cyclase. Okay. Adenylate cyclase, okay, activate adenylate cyclase will, so they bind to receptor, so the receptor will activate adenylate cyclase. Adenylate cyclase will convert ATP into cyclic AMP. Cyclic AMP will activate protein kinase A from the inactive form to the active form. Protein kinase A will phosphorylate calcium channels. Phosphorylated calcium channel will allow passage more, but they can allow passage or increase calcium flow into the cell. This will increase the force of contraction. Okay, so the phosphodiesterase inhibitors, they deal with cyclic AMP, but in a different manner than the beta agonists. They inhibit the inhibitors. Okay, they are phosphodiesterase inhibitors. So the phosphodiesterase enzyme itself breaks down cyclic AMP into AMP, adenosine monophosphate. These inhibitors will inhibit that part, so I can keep the cyclic AMP, which again activate protein kinase A, which it's kinase. It will add phosphate group to, so cause phosphorylation of calcium channel, which allow more of influx of calcium. Okay, I think that's it. So now these two mechanisms in one, two in one. Okay, like the shampoo, Head and Shoulder, two in one. Okay, the last group, alhamdulillah. Inotropic agents, the beta agonists. This is kind of the only time in my life I see agonists and antagonists are used for the treatment of disease. We talked about beta antagonists before, remember? Talked about metoprolol and others for the treatment of heart failure. We talked about the suggested mechanisms, and here also agonists could be used, such as dobutamine, selective beta-1 agonist, so it will enhance the contractility, as we just discussed now in the mechanism. It will increase cyclic AMP, cyclic AMP activate protein kinase A, phosphorylation of calcium channel, more inward or flow of calcium. Okay, this will again decrease the ventricular filling pressure, like what we said about digoxin. Okay, we said when we increase the cardiac output, there is decrease in the systolic volume and decrease in the ventricular filling pressure. Okay, it's used for short-term support of circulation, advanced heart failure. Okay, however, may lead to tachycardia, may increase oxygen demand. Okay, may produce angina, arrhythmia. Okay, patient coronary artery disease. Okay, and also tachyphylaxis that accompany use of beta agonists. Tachyphylaxis means the loss of drug's effect when it's given for a long time or repeatedly. Okay, so the patient taking the drug at the same dose at the usual time in the day, everything. Okay, the patient's completely compliant, but the body is afraid of the excessive activation, so there will be kind of down regulation of the receptors. So this is what's called tachyphylaxis or loss of drugs effect was given continuously or repeatedly. Okay, intermittent dopamine infusion may benefit some patients with chronic heart failure. Okay, dopamine also can activate beta-1 receptors that have been used in heart failure, maybe particularly helpful if there is a need to raise blood pressure in patients with hypovolemic shock or severe shock or something. But these are kind of, rarely used. Okay, and the mechanism of action we just talked about the activation of adenylate cyclase, which will convert ATP to cyclic MP protein kinase A phosphorylation of calcium channel. I think that's it. Thank you so much for your patience and your attention, all of these for lectures, and I wish you benefited, and I wish to see you again, and have a wonderful day. See you later.